Welcome to 2-minute anaesthesia in critical care. Let's discuss coagulopathy. A coagulopathy is an abnormality of one or more haemostasis components, i.e. thrombocytopenia, an abnormally high PT, INR or APTT. Sometimes this term is used to represent both hypercoagulable and hypercoagulable states. The incidence of coagulopathy in critically unwell patients is high. Thrombocytopenia affects up to 40% of patients, and an abnormally high PT or APTT can affect up to 60%. Haemostasis is a complex process which involves three basic stages: primary, secondary and tertiary. Primary, the formation of the platelet plug. Secondary, the formation of a stabilised fibrin clot throughout the coagulation cascade. And finally, tertiary, the formation of plasmin for the breakdown of fibrin via fibrinolysis. These processes occur simultaneously. Now let's discuss primary haemostasis, i.e. the formation of the platelet plug. Initially, there may be endothelial injury results in exposure of collagen, which is able to bind to von Willebrand's factor, which is secreted into the subendothelial space. Platelets then bind to the von Willebrand's factor by GP1B. This results in the platelet activation, leading to a change in shape and release of a range of factors, including additional von Willebrand's factor, calcium, ADP, and thromboxane A2. Thromboxane A2 and ADP result in GP2B3A expression. GP2B3A binds to fibrinogen, linking platelets, thus forming the platelet plug. Now let's discuss secondary haemostasis. Is defined as the formation of fibrin through the coagulation cascade. The coagulation cascade has three pathways: intrinsic, extrinsic and common. And there's a range of clotting factors which are expressed as Roman numerals or numbers, and once activated, the letter A is present after that number or Roman numeral. Firstly, let's discuss the extrinsic pathway. Vessel injury leads to the release of tissue factor from endothelial cells, which activates factor 7, forming factor 7A in the presence of calcium. This pathway is measured by the PT or prothrombin time, which is affected by warfarin. Now let's discuss the intrinsic pathway. It's a little more complex. Factor 12 moves freely in the plasma until required. It binds to negatively charged phospholipids on platelets and subendothelial collagen, resulting in activation, forming factor 12A. Factor 12A cleaves factor 11 to form factor 11A, and factor 11A and calcium cleave factor 9 to form factor 9A. Both extrinsic and intrinsic pathways lead to the activation of factor 10, forming factor 10A. Factor 10A then cleaves factor 5 to 5A, and factor 10A plus factor 5A and calcium convert prothrombin factor 2 to thrombin 2A. Thrombin then converts fibrinogen to fibrin, and fibrin cross-link form is achieved in the presence of factor 8. Factors 2, 7, 9 and 10 require calcium, and the vitamin K dependent clotting factors are also 2, 7, 9 and 10, in addition to protein C and S. The development of a coagulopathy is multifactorial, and the diagnosis may be difficult in the presence of changing physiology in the critically unwell patient. They may be classified in different ways, but examples include those which affect primary, secondary, contributing factors and hyperfibrinolysis. Primary haemostasis could be due to reduced platelet formation due to bone marrow infiltration, infection including sepsis of any cause, drugs and alcohol, increased consumption of platelets due to ITP or HIT, and also microangiopathic states, TTP, HUS, DIC, in addition to pregnancy-related factors. The sequestration of platelets in the spleen due to portal hypertension of any cause, for example cirrhosis or CCF, and splenomegaly of any cause. Secondary haemostasis due to the formation of clotting factors could be abnormal due to dilution, vitamin K deficiency, DIC and a range of drugs. The contributing factors are required for activation of the coagulation cascade, so hypothermia, acidosis or hypocalcemia can affect this, in addition to hyperphenylatic states, including major trauma and surgery. Coagulopathy with the normal coagulation test can affect due to platelet dysfunction in the presence of uremia, liver failure and drugs, and hyperfibrinolysis due to malignancy. The management relates to management of the underlying etiology, clear diagnosis, and the correction of defects if clinically indicated. A range of factors can be given. Examples include FFP. This is formed by the centrifugation of one blood donation and removal of the top liquid. These contain all clotting factors, and the usual added therapeutic dose is 15 ml per kilo. Cryoprecipitate is available as a single unit or as a pool product made up of 5 single units. Pool units are more commonly used to treat adults. These are rich in factor 8, fibrinogen and Von-Willebrand factor, and is used to replace fibrinogen. Prothrombin complex concentrate, i.e. Beriplex, contains factors 2, 7, 9 and 10, and is used for warfarin reversal. Recombinant factor 7A is a man-made product to replicate the naturally occurring activated factor 7A. And finally, tranexamic acid competitively and reversibly inhibits the activation of plasminogen. The consequences of coagulopathic states can be bleeding, and this can be important in certain compartments, for example the brain, which leads to an intracerebral hemorrhage. Coagulopathic states are associated with increased length of stay and increased mortality. Once again, thank you for watching.